Again, everyone. My name is Swazi Hlope. I am a fifth year medical student at UCT, and we'll be chairing today's session. So today we are going to be starting with reviewing Prince Mshiyeni Hospital that is in Durban, KwaZulu Natal, and we would like to welcome Dr. Mbhele, who will be reviewing the hospital for us today. Dr. Mbhele.
Hello, can everyone hear me?
Yes, we can. Welcome. Thank you so much for availing yourself for today's session.
All right, no problem. So yeah, I'm young Mbhele. I'm basically a second year intern at Prince Mshiyeni Memorial Hospital. As you stated, it's situated in Durban, along Durban South to be exact, in Umlazi, around the V section area. So there's a drainage population from Umlazi, also includes certain portions of the South Coast, all the way bordering Escosburg, also Lamont as well. So it has a huge drainage population. So it's like the second busiest hospital in the country, second to Bara. So you can expect, which if you come to Prince M, the workload's quite a lot. In terms of the quality of the life and the workload and so forth, it's block or rotational dependent. So basically, during the first day of internship, you rotate through firstly the four main rotations, which are your internal medicine, obstetrics, pediatrics, as well as general surgery. Prince M usually has an intake of about 78. It can go all the way up until 98 interns, and then they generally have also another mid-year intake. Because the previous year they had 110 interns, the year before us, and then during our year we had about 89. And then this year it was quite unfortunate. The number was drastically reduced. I think they had like 49. Hence why there was like a lot of issues this year. But so as far as I heard, they increased the intake is back to like 90, from what I heard. Yeah. And then in terms of the hospital itself, like I said, the quality of the work, the calls, they all differ per the rotation. So I'll just go quickly through each rotation and then give you like a brief idea in terms of what's expected of you, how much is the workload, how much supervision do you get, in terms of like the academic support as well, and teaching structures that are available here. So I'll basically start off with the first rotation, internal medicine. So yeah, this one is the most hectic rotation. So typically, so I guess you'll be split into different groups, four groups. So typically we had about, I think we had about 20 interns or so during the time we rotated in internal medicine. It's the most hectic rotation in terms of the workload, in terms of the number of patients that you see, and also in terms of the calls themselves, because internal medicine is quite a hectic rotation. You rotate through MOPD, which is the less, like it's more relaxed. You rotate there for a month. You also do your course there at MOPD for a month, and it's much better there. Post call is usually at about 10 o'clock, and you usually see stable patients most of the time. But then you usually are in the ward for about 2 months, so out of your 3 month rotation. And then when you're in the ward, you allocate it into teams. So there's 6 different teams. Each team has about 2 interns. And then you choose amongst yourselves which one will go to the male or which one will go to the female side. But you generally belong under one team, and you will have MO medical officer overseeing each team, so the female side and the male side, but there's one consultant that oversees the entire team together. So even though you are working in different areas, you are one team. So the amount of work that you have and what time you finish at is dependent on the teamwork that you have amongst yourselves. So if you guys are able to work together as a team, like let's say the female side has less patients and you have less of ward work to do, then you can go and assist your colleague at the male side. So I generally had a very good team. We used to always assist each other. So we used to always finish at around about 1 o'clock or 2 o'clock. There was no time when we spent, because I used to see some teams used to finish at 6, sometimes at 7 because of the workload that they had. And that's generally because people didn't embrace the fact that there's teamwork. So if you guys work together as a team, yeah, you can finish quite early. And then in terms of the calls when you are in the wards, you do calls at MAR, that's like the medical emergency room. So you deal with mainly like emergencies that side, patients that are desaturating, patients that have hypoglycemia, DKAs, also new patients, like new psychotic patients. Yeah, and then generally there's no like allocated post call time. For internal medicine, there's no post call. You guys will determine when your post call is. So when you have a call, consultant usually comes in the morning. By that time, he expects everything to be done, the results to be prepared, all the patients to have been reviewed during the night. So if you guys work smart, like you anticipate certain things, like if you see a CVA patient, you do the entire workup. You start writing consults for physio, for dietitian, for OT beforehand. And in the morning, you just hand out the consults. And also, when you're taking bloods, also make sure to take an extra tube for yellow, for purple. And then in the morning, you can just call the lab if the consultant adds any specific bloods for that particular patient so that you can get to in the morning, just wrap up the urgent things such as LPs and then also patients which need to be taken to CT for urgent CT scan. And then you can have your post call before 12 o'clock. Yeah, and then in terms of the academic side of internal medicine, I would say it's not so good. Like it's very bad. The main source of like academics that you get are the intern presentations, which usually take place once a week. But most of the time, it's usually just an excuse for the HOD and other people. They usually bash the intern presentations and so forth. So it's not really good when it comes to the academic side. So if you're passionate about internal medicine, I would not advise you coming to Prince M. So yeah, that's internal medicine. It will basically be the most hectic time that you will have during internship. So if you can survive internal medicine, yeah, you can probably survive other rotations. So also have pediatrics. So peds is the more well balanced of the rotations. You rotate again through POPD for about a month or PRU also for about a month. Either they allocate you at POPD or PRU. Other places that you can get allocated is you also either get allocated at nursery or at postnatal wards for about a month there as well. Postnatal wards is generally see about 5 wards, but most of the patients there are stable patients. There's not much supervision. But if you see that there's an issue with the patient, you usually go and discuss with nursery or there's a senior that is allocated that you can discuss with, and yeah, they can review the patient. If you're in nursery, there's generally a lot of supervision there, and you'll just basically be rotating through the prem side, the term side of nursery, You don't really see patients that are in NICU or the patients that are in high care, but you will do like some of the ward work that's allocated that side. And it's generally relaxed. Most of the seniors that are there, they oversee a lot of the things, and consultants generally around there quite frequently. So yeah, there's a lot of supervision there, and you'll also get to learn a lot of things. Yeah. You also get to rotate in the wards um, as well. There's one for P1, which is one for patients between 6 months and above, and then there's P3, which is usually for patients below 6 months. So from 1 month all the way up until 6 months. And yeah, you rotate in the respective wards for about a month. Also, there's MO which oversees the work that you do there. There's generally a consultant who rounds every day. So your job when you're in the ward is to basically see the patients, make sure that you do the ward work in time, and then fill out discharge summaries. And yeah, you get to learn quite a lot, especially in the wards, because there's a consultant that's there to oversee most of the things, and also the seniors are willing to teach as well. PEAS is also very nice in terms of the academics aspect, because there's usually presentations when it comes to ETAT, as well as common pediatric conditions that you may come across in the wards and in hospitals. So yeah, and generally, the academic side is also very good, and the practical side is also very good. And also in POPD, that's where you basically see the outpatients. Those are mainly stable patients. And then they run like different clinics on different days. They may have an epileptic clinic, and then other days they may have a neuro clinic. It basically differs across. But yeah, POPD, that's generally when it's usually the most relaxed that you can get. And then in terms of the calls, the PEDS calls, you have, so you can either do your calls at nursery or do your calls at uh, POPD and PRU. So if you're in nursery, most of the times the calls are generally relaxed, because MOs usually they're the ones that see the patients. You just do the ward work, tracing results. You may see patients on the term and prem side, but it's usually your more stable patients. And the ward work, which is usually just doing bloods, TSBs, making sure that all the results are traced before the ward round, which they do a telephonic ward round with the consultant at 7 o'clock, also another one at 12 o'clock at night, and then also the one that usually happens in the morning. And then around, they usually release you after the ward round in the morning, and then depending where you allocated. So if you allocated a POPD, you can always go immediately after the ward round. But if you're in the wards, that means post call is usually at about 10 o'clock. Um, yeah. Yeah, that's pretty much it about pediatrics. Then the other rotations are surgery and gynecology, obstetrics and gynae. So obstetrics, again, it's fairly well balanced rotation. It's actually one of the best in terms of how it's structured at Prince M. Again, it's very academic. You get to do a lot of, it's very academic and also very hands-on. You get to do a lot of procedures. It has a high, because we have a very high birth rate here. I think sometimes it even borders like 1.8 all the way. You can have as many as 2,000 deliveries. It can even go up to cutting about 800 Caesars per month. So it has a very high rate. So for obstetrics, you will get to cut a lot of the Caesars. You get like a very hands-on practical experience. The seniors here, they will allow you to cut. None of them fussy about cutting. They allow interns to cut. Even consultants encourage them to allow interns to cut. So you, by the time that you finish the rotation, you will meet the prerequisite, which is I think 10 Caesars that you must complete before the rotation finishes. And then you also have the academic aspect. So ASMOs, so usually every morning from the beginning of the rotation up until the middle of the rotation. And then did I forget? Yes, the consultants are very hands-on. They're also willing to teach, so you learn quite a lot. And then in terms of the calls in obstetrics, so you do have somewhat of a pre-call. So you run in the postnatal side where you just see the mothers and you just discharge. Usually, you see post-NVD patients. There's three of you that will be on call. Guys see the post-NVD patients. By 9 o'clock or even 10 o'clock, you're usually finished. So you get like sort of a pre-call beforehand, and then at 4 o'clock you then go and start your call. Your call will be at labor ward. So you cover labor ward, you cover admissions, you also cover the maternal high care, and then theater. There's usually a second year intern from family medicine that gets to join you guys. So you'll be three first year interns and then one second year. And then how you guys delegate to distribute the responsibilities amongst yourselves. But admissions has to be covered. That's basically like new patients that are coming in. And then labor ward, that's the floor, basically booking patients, making sure bloods are done. Then maternal high care, that making sure again that bloods are done for patients, results are traced. If there's a transfusion that needs to be done, it's done as well. And also we do midnight bloods. And then in terms of like the post call is usually around it is at whatever time. As soon as the ward round ends from the high care patients to the patients in labor ward, you can go. But it's dependent on whether how quickly you guys do. Because in the morning you also have to see post Caesars patients in the postnatal ward. So if you guys are smart, and then you can start rounding at around about 5 o'clock or at 6 o'clock. By the time the ward round starts at 8, you guys are finished rounding and you've seen all the patients. So as soon as the ward round finishes, you can go. So that's it. And then the gynae side, you round between GOPD and there's a gynae ward. Again, also very practical. The consultant that rounds there, she's usually hands-on. She will teach you a lot of the procedures. You do a lot from your PEPALs, your pap smears, to your punch biopsies, to MVAs, and you learn quite a lot when you're rotating there as well. And then you also rotate at GOPD, where you're also expected to do most of the procedures that I mentioned, and also help in terms of like tracing results and so forth. Yeah. And yeah, when you're rotating between gynae and obstetrics, yeah, the calls are the same, whether in the gynae area or on the obstetric side, you do your calls the same way. Yeah, and that's basically gynae. And then gen surge, um, it was, yeah, my favorite rotation, because it's quite well balanced. Again, it's like similarly to gynae, there's a lot of the academic side. There's also a lot in terms of like you learning practically how to do a lot of the skills. It's very hectic in terms of the trauma side, especially month end. Um, During the weekends, you will see a lot of trauma patients, stab abdomen, gunshot wounds, community assault, soft tissue injury, all those things. You'll see a lot of them. But what I can say is that the department here is very hands-on. And the seniors, they look after you, they make sure most of the time they'll be around, and also they are willing to teach you. So you learn how to put up a chest drain, you learn how to put up a CVP, you'll be comfortable in doing all those things, doing incision drainages and so forth. Like you'll learn a lot of the skills practically. And then from the academic side, they also is very good as well. You just you rotate between different departments. Like the wards, you rotate for about 2 months. The male and the female ward, sorry. And then because it's quite different in some of the epidemiology between males and females. Like from the male side, you see a lot of the trauma patients. Female side, that's where you see like your genuine like surgical cases. And
Um,
then, yeah, the other month you basically be rotating between the pediatric ward. There's also a short stay and other departments. So
mm,
yeah, that is basically general surgery. The calls, it depends. Midweek, the calls are not bad, but month end calls are very hectic.
mm,
And generally, the post call is around about. It depends. It can be 8 o'clock. You can go at 9 o'clock, but latest is probably 9 o'clock that they will release you at. Yeah, and then
yeah.
that's basically first day of internship.
Thank
Um,
Thank you, Dr. Mbhele. I think just because of time, I just wanted for the work experience specifically, if we could just pause here at first year, and you've given us such a good idea of what to expect, especially within the work environment. So thank you so much for that. I would like for us to kind of move towards the living environment. So do you have information about the DQs or like living environment nearby? If we could talk about more the neighborhood, the area, and living arrangements.
in terms of like the living environment here, DQs is not in like such a great state. You can either be allocated a DQ at nurses' home. Nurses' home tend to have like smaller living arrangements. You also get to share like bathroom with like people that are on the same floor as you. Whereas DQ, the rooms are more spacious. You have a small area for you have your own bathroom. You also have like a small allocated area for like your clothing and stuff. So yeah, and in terms of that environment, it's quite close to Durban. So you will be able to move around quite a lot. Because I know people are interested in terms of like, do you need a car here? No, you don't need a car if you're living in DQ. That is because it's quite close to Durban. It actually is in Durban. And you can move around using Uber, you can move around using Bolt, and there's a lot of places that you can go around here. So in terms of like having fun and so forth, yeah. Um,
Right. Thank you. Thank you very much. And okay, so we get into more specific questions afterwards, but I do just want to ask about, the burning question, what everybody wants to know, what
salary.
the salary is. Are there allowances? If they are, how much?
All right, all right. Oh, yeah. Prince is we don't have a rural allowance, but we have something equivalent to that. We have a risk allowance because of the area that we're situated in. Mainly because to be quite honest, there is quite a lot of crime which does happen around us. But the Prince M itself is quite safe, like the hospital. There's not many. You won't hear incidents happening inside the hospital. So there is like a 22% risk allowance. So it's equivalent to a rural. So your take-home salary is around 52K. That's after they've deducted the cost for ATQ, which is usually 900. So it's around 52K. So it's equivalent to someone going to rural hospital. in the actual sense. But the advantage is that you're in an urban area and you're quite like closely situated to Durban. You are in Durban in the actual sense. So yeah.
Thank you. Those are good numbers. Those are definitely good numbers. So thank you for that. So I do have a few questions that were sent through beforehand. So I'm just gonna go through those, and then afterwards we're going to be taking questions in the chat. So if there's anybody in the meeting who does have a question that they'd like to ask, please just put it in the chat, and then we'll go through those afterwards. So the first question that I'd like to ask you is how would you rate your experience at Prince M? Do you feel as though you got what you were looking for? And are you happy with the experience? Do you feel competent? Those kinds of things.
I feel like the experience that I got from Prince M was very good because particularly I knew what I was getting myself into. Like when I said at the beginning, we have a large drainage population, so we have a large number of patients that you will see here. But the exposure is very good. The teaching is also very good, not just from an academic side, but from like a practical point of view. In terms of competence, I feel fairly competent. I feel confident enough because I've rotated through family medicine, and I feel like that's where you get to test. Because I rotated to family medicine 6 months in a district hospital. So it was almost like a dry run in terms of like ComServe. And yeah, I felt like the Prince M had equipped me a lot. So I would say I do recommend the hospital, but be prepared that you will be facing like a lot of work, especially in specific departments like internal medicine, obstetrics and gynae. Yeah. But most of the time, if you can work in a group setting, if you can, as time comes, as time goes along, you get more adapted to the working environment. You also have like strategies that are in place to like how you work, and you won't be like you won't be going at like 4 o'clock. So yeah, so those are the things that you, and also when you get here, speak to people who've done the rotation before you, like like second year, speak to them. They'll give you like a rough idea, and they'll tell you, okay, heads up, this is what you do. That's what I did essentially from the beginning. I spoke to someone that I knew from UKZN, and they used to always give me like a heads up before each rotation. Okay, do this, don't do that. Well, and that sort of helped me to adapt quite quickly when it comes to rotating between the rotations.
Okay, thank you. And how would you say the work-life balance is? And specifically on the mental health side of things, would you say that being at Prince Edward took a toll on you or takes a toll on others? Um, how would you say the balance is?
The balance, there's a lot of work here. I'm not, like, I won't even sugarcoat it. There's a lot of work. There's a lot of work, but again, like I said, you must just learn how to strategically do things. Like, for example, I used to have a friend that used to, like, doing internal medicine. They used to not do all like the ward work, leave like a few bloods, and then come early in the morning, mark them urgently. So those are the things that you can sort of do. And then if you're in a team setting, you could always text, like I could always text my colleagues that I was rotating with, if I was like having a lot of work, and then ask them if they can assist me with certain things. And also, if you're rotating with someone in a particular ward or area, make sure that you guys do the work, and also make sure that you distribute the work equally and help. Yeah. But in terms of the workload, it is quite a lot. Um, but you adapt to it, and then you learn to formulate strategies like as you're going through the different rotations. And in terms of like the work-life balance, in the beginning it's quite overwhelming, but as time goes, you literally get to balance it out, and you get to see that no, because I remember we had a lot of fun first year. We had a lot of fun. We used to go out quite a lot. So yeah, because you are in Durban, essentially, you will end up going out. And yeah, I would say I recommend Prince M. You can come here, but be prepared. There are times where the workload is quite overwhelming. But as time progresses, you get to adapt,
Yeah.
especially like sometimes during the first month, like people who haven't rotated in UKZN, they have difficulty like moving around, and so forth. But as time progresses, you get to know certain things. Okay, here's the lab, here's whatnot, and then you get to be more effective in
I
your work.
see.
So
Thank
yeah.
So we have received a few questions about language, being that it's in. And do you think that someone who doesn't speak Zulu would be comfortable and would be able to, or is only English speaking, would be able to comfortably place themselves in Prince M?
Realistically speaking, no. Like you have to at some point make that leap to try to learn isiZulu, because most of the population here, I would say maybe less than half, maybe 30% of people will understand both English and isiZulu. Most of the time they will purely speak Zulu, so you must learn. But I've seen a lot of people come from different provinces here, and then they have adapted and like learned the language. Because most of the time, you will be expected to interact with patients that do not know English at all, and yeah, the only language they speak is Zulu. So yeah, because majority of the time, people either speak English or Zulu, but I would say probably 70% of the patients here they will speak isiZulu, and then a small percentage will speak both the languages. They may understand English and so forth, but
Yeah.
you really need to know isiZulu. If not knowing like how to speak it, but then you need to understand it. Yeah.
Okay. And are there any kinds of assessments that you go throughout the blocks? And if yes, what assessments are there? Like to assess whether you pass the block.
Yes, there are assessments. For P's, for example, you get assessed every single month per the department that you're rotating in, and they usually ask like common questions based on like things that you've seen. Like if you're in nursery, they'll ask you how would you manage pathological jaundice, or what are the common causes of respiratory distress in neonates, and how do you approach. So they ask those common things. You get assessed every month by the consultant that's in that area that you are allocated in. The other rotations, no, they don't really assess you. They assess you based on how you work, and then they make that assessment. There's no like formal academic assessment. The other assessments are usually done for other rotations in second year, like anesthesia. They're quite a very structured assessment, but it's very like anesthesia is a very academic department as well. And like it's the most academic here. And then the other one, I think, ortho also has like some form of assessment. I think it's a written exam. Anesthesia has a written exam. Oh, before ONG also has a written exam as well. But it's also things which you've usually seen in the wards, or things that you've come across throughout your rotation. as well, and they're quite an academic rotation. So yeah, it's a written exam. I think it's out of 120, the one for obstetrics. Yeah. So those are the only like formal testing that we have.
Okay. Okay. Well, since we're kind of on second year blocks, I did see a request in the chat for you to just very quickly kind of hit through the second year rotations as well.
All right. So
Thank you.
second year, you basically rotate through family medicine, which is a 6 months rotation. You are split into essentially three groups. One small group of about 10 people. They go to a district hospital, which is in Scottsburg. It's GJ Crooks Hospital. It's a very nice rotation there. You rotate for about 6 months, and then you rotate through various departments. Like for 1 month, you'll be in maternity, another month, you'll be in casualty. Also, you rotate through the clinics as well for about a month, and then you rotate through the medical wards, the surgical wards, as well as the pediatric wards. It's almost like a dry run, basically, there in terms of ComServe, because it almost like mimics how ComServe will be, because you'll be in a district hospital for about 6 months. The teaching there is very good because you have a family physician that's there who teaches quite a lot. She oversees the program. So it's a very good program. I was there for about 6 months, and it also like gets to allow you to test yourself in terms of how much you've been able to gain from like first year internship, because family medicine encompasses all the aspects of medicine. So yeah, and then you basically will be referring to Port Shepstone Hospital, which is a regional hospital, that the one that GJ Crooks works with. So yeah, it's a very good rotation. But if you do go to GJ Crooks, you may be forced to get a car. Um, Although the hospital basically rents a place for you. It's about a 5 minute walk from the hospital, but you may need to get a car in terms of like getting to and fro for calls and stuff. Yeah, the calls there, they're not as hectic as Prince Mshiyeni, but you do your calls in casualty, and also as an intern, you are expected to assist in theater for emergencies, C-sections at night. So yeah, and post call is usually around 8 o'clock. Um, and then the other rotation that I've done is I'm currently doing psychiatry. Also very chilled rotation. You basically split into different teams, and then you see patients at the psych outpatient department. You also get to see patients from like different disciplines that have sent out consults and other things. And then the calls for psych are done at MOPD, the medical outpatient department. Yeah, and usually post call is at about 10 o'clock. But they release you from 8 o'clock, depending on which team they've placed you under psychiatry. And then from academic side, yeah, it's fairly well balanced. We have presentations, consultants are also around, and they do teach. And we also have like a grand ward round once every week or so. And there's a lot of teaching which happens during that time. The other rotations I can't speak for because I haven't done them. But from what I've heard, anesthesia is also very good. It's very academic. Um, Also very practical. You get to do a lot of things from intubating, extubating patients, and also yeah. And also they have like a formal assessment, they have a written assessment, I think, and then they also have like they give you two patients that you have to prepare, one for general anesthesia and one for spinal. So yeah, and then ortho, very busy. Um, yeah, it's very busy from what I heard, but I heard it's also very academic. There's usually morning meetings. You're also expected to like present patients that you've admitted overnight and interpret X-rays and so forth. Yeah, but I haven't rotated through the rotation. I also heard there's a formal assessment there, but I haven't inquired much about it because it's my last rotation there. So yeah, that's basically second year of internship.
Okay, thank you so much, Dr. Mbhele. So another question that we received is how resourced would you say that the hospital is? And then, yeah, so how resourced would you say the hospital is?
Resources, it depends. Like sometimes you get there and you have the proper resources, and then sometimes you get there and things are chaotic. Like we had a month, we had like a specific period of time where we didn't have CVPs. The entire hospital didn't have simple things such as CVPs. So, but in general, most of the time it's fairly resourced. I wouldn't say well resourced because you'll be looking for something and you'll have to headhunt for it. You'll have to look for it in other wards. It just depends on where you're rotating and how well structured is the ward that you're rotating. I'd say the surgical wards, most of the time, they're well resourced. Medical wards, they're just very chaotic. Like medicine in general is a very chaotic department. So yeah, yeah, it depends. Depends. But yeah, but I would say it's fairly well resourced.
Okay, okay, thank you. There is a question about which other places or hospitals, clinics, district hospital, that as you've already mentioned for family medicine, but besides family medicine, are there any other rotations where you're going to have to travel, and how far away are those clinics?
Oh yes, I actually forgot. Thank you so much. I forgot to mention. Yeah, I was thinking about my own experience with family medicine. There's two different groups, right? Besides the one that goes to GJ Crooks, there's also the other groups. So you get to rotate in another district hospital called King Dinizulu. Um, which is close to Prince M. They provide you with transport when you're going to King Dinizulu. So you spend 3 months at Prince M and you spend 3 months at Dinizulu. When in Dinizulu, you rotate through maternity, through casualty, and through the general wards. Prince M, you rotate through Gen Surge, through where you do your calls on casualty, you rotate through PEDS, where you do your calls on PRU, and then you also rotate through um, maternity where you do your calls in obstetrics. And then you will also be rotating through Gateway Clinic at Prince M, and there's a chronic clinic where you see mostly like TB patients and so forth. There's also clinics that are attached to Prince M from, there's a lot of clinics. I think there's about, if I'm not mistaken, 12 to about 14 clinics attached to the hospital. So you may rotate through them when you're rotating through family medicine. I just don't know these ones because I rotated at GJ Crooks for 6 months for family medicine. So I am not familiar with the ones that they rotate through when they're doing family medicine here at Prince M and King Dinizulu. So I only know like the figures in terms of the 12 to about 14 clinics. So I'm not sure like, how things work and so forth. But from what I've heard, people generally, if you're rotating in the clinics, they will provide you with transport um, that will drop you off and pick you up as soon as you're finished. And they usually finish by like 12 o'clock. It's usually like the most enjoyable aspect of rotating through family medicine is the clinics time. So yeah.
Okay. Thank you. So there are a few questions that are in the chat. So the first is, can you speak a bit more about senior support? And on average, how many calls do you work in a month?
Like, pardon? Can you please repeat the part about support and stuff?
They were asking if you could please just elaborate more on senior support.
Oh, senior support. Like I would say, the support is, again, it's dependent on the rotation that you are in. And then the average number of calls that you get per month, again, it will depend on the rotation that you're in. For example, but I would say overall, the senior support is very good. Like, seniors most of the time will avail themselves. They'll be around to support you, especially when they're not so comfortable, like during the beginning of the rotation when you're still trying to adjust to Prince M. But as time progresses, they get to be more comfortable around you as well. But the support is very good. You do have like one or two incidents where seniors do disappear, and those people are known throughout the hospital. So yeah, but in most of the time, you will have like during a call, your senior will be there. If they're not there, they will tell you where they are and how to contact them. And when you need them, they will come through. Number of calls per month, purely rotational dependent. Internal medicine used to do like one call every 6 days. Gynae, you can do like 5 to 6 calls. Surgery, it was also about 5 calls per month. Peds also in that range as well. Um, it gets less hectic in second year, like psych, we have about 4 calls. Family medicine, we had 4 calls when we were in GJ Crooks. And then I haven't rotated to the other departments, like anesthesia and orthopedics. I think ortho, they said 5 to about 6 calls. Anesthesia, I think it ranges about there as well. But the nice thing about it that there's pre-call and post-call is usually at um, I think 7 o'clock.
Okay. We received another question that was asking for someone who would love to continue studying, someone who loves to prepare for primaries and something like that. Do they really get time to study?
Yeah, Prince M.
Yes. Would you be able to? Would you have time to do your primaries?
No, like primary is okay. Okay, like first thing, primaries, you will only be eligible to write your primaries during ComServe because you have to have at least worked in a rotation for about 6 months. Yeah. So I can't comment much about it because we're not eligible to start writing primaries. But I've seen people prepare for ATLS, your BLS, ALS as well. So it's dependent on you how you manage your time efficiently. But
Oh,
as you get through the rotations and as you like become more efficient with your work, your life becomes balanced out. Your
mhm.
work is no longer overwhelming. But in the beginning, yes, when you're still like trying to adapt, trying to figure out a lot of things, it will be quite overwhelming. But as time progresses, you get to learn how to juggle those things.
Okay. So we have a few questions about the DQ. The first being, is it fully furnished? The second being, if you don't want to be in DQ, which areas are around to be able to kind of rent in, and how far is the DQ from the hospital?
DQ is within the hospital itself. You can
Yeah.
walk, like you'll probably be within the wards in less than 5 minutes. It's within the hospital. Hence why I was saying if you live here in DQ, you probably will not need a car. You can actually survive your entire internship without a car. although it won't be convenient in terms of like you moving around Durban and so forth, but there's still Uber you can move around. But you can get through your internship without a car, and it's not fully furnished. The only one that is a nurse's home. They will furnish you with a bed, also a couch as well. So those are the only things. If you're allocated a DQ, you can stay at nurse's home, where it's somewhat furnished for a while, and then once I think at month end, once your first salary starts kicking in, when you have enough funds, you can start furnishing your place at DQ. So DQ, there's you usually get here, there's nothing.
All right. And are there any
Places
areas
around.
around? Yeah.
Oh, most of the people they end up going to Doti. You can rent anywhere within Durban, because it's not far from Durban, but you'll have to travel on a daily basis.
Yeah.
Then that means you'll have to get a car, and then yeah.
Okay. And for people who are willing to travel, would you say, because there's a question that's asking about the environment safety, traveling to and from the hospital if you're leaving at late hours. Someone even asked about if they are a polo driver. Would you say that it's safe for them to drive in and out in the late hours?
No, like honestly, yeah, you have to be wary with. Okay, yeah, you are in Umlazi, so you have to be wary of that first of all. Like you must be cautious at all times. But in general, if you're in South Africa, you must be wary when you're driving at night, wherever you are. But in Umlazi, it tends to be, yeah, you have to be more cautious than most.
Yeah.
But I haven't heard of any incidents that have happened to anyone. I have friends that live in Manzim. No, they live in Umhlanga. I have about two friends that live there. They're renting that side in Umhlanga. So I don't know what the prices are like, but I can say it's quite hefty. But you can try and see which areas of Durban you can rent in. Uh,
Mm-hmm.
and then, yeah, based on what you are willing to pay financially, and then also take into account of traffic, like moving in and out every day. But generally, this area is it's safe. Yeah, that's all I can say. Um, what else? What did I want to say? Yeah, that's basically.
Okay. So we do have a few hands, and I think that in the last two minutes, if we can just take hands. Well, I see your hand is up.
All right, yeah. Go ahead.
Sawubona, Doctor. Can you please describe your experience in terms of working in a hospital that you used in medical school and working with seniors that taught you in medical school?
I would say for me, it was easier for me to adapt to Prince M, because I rotated here for internal medicine as a student. B, there was a lot of people that I knew from the second year interns. So I already knew what the DQ was like. People have already sent me pictures what the DQ was like. And each time I went into a rotation, there was a guy I usually spoke to from medical school, Kenneth. I usually used to speak to him most of the time, and beforehand, like he took me out, we went, we spoke, and then he just broke down Prince M, like what to expect, and this is how you work, and then this is how you work smart, like this is how you do things strategically. So it worked in my favor, because I knew what to expect, and I was not really shocked in terms of like the workload, because I already knew beforehand. Okay, it's going to be a lot of work. Okay, but this is how I approach rotation. Things like communicating with people before, because it takes quite some time for lab track to be registered. Such as a simple thing as tracing results, it takes some time because they have to submit paperwork to the clinical manager, to the HODs, and then the lab will then process your things, and then you'll be able to access lab track. But because of the fact that I already knew a lot of people here, I already had things, access to things such as like that. So I would encourage that if you at least try and know someone, and then if not, if you don't know anyone, speak to whoever is like a second year intern. Speak to them, and they're always like we're always willing to like give you like sort of smaller orientation in terms of like what to expect and so forth. And it's always nice to see people that recognize you as seniors as well. So it was much of an easier like way for me to adapt and work. Yeah.
Okay, thank you so much. Thank you, Dr. Mbhele. I think just one very last question, just because it hasn't been touched at all, that was sent in the chat, was a question about racism. Is there racism, and is that something that they should look out for in like the last 30 seconds?
Racism, no. Prince M, no. I wouldn't say no, honestly. I wouldn't say there is. Just that you must like you do need to know or try and adapt towards speaking. This is
Mm-hmm.
that's a give and take.
Yeah.
You can't escape that. You can't escape it. Because predominantly people who are around here, they'll speak isiZulu most of the time. Racism, I haven't encountered many issues in terms of that. No.
Okay. Thank you so much, Dr. Mbhele, for your time and for giving us such a good idea of Prince Mshiyeni, and kind of opening our eyes to making sure that we're applying that we know and understand. So thank you very much. So for any other questions that anyone might have, Dr. Mbhele has agreed to give you his contact. So I'll be putting his number in the chat, and then any other more directed questions, you can just ask him. Thank you so much, Dr. Mbhele.
All right. Thank you.
Thank you. So I know that we have another session starting now. I just wanted to ask if we could give maybe 3 minutes, grab some water. I'm going to do the same, and then we'll be back at 5 past to start our next session. Thank you.